This presentation is about care for the high-risk newborn. It is really just a brief overview of some of the most common problems that you may see. Care for the high-risk newborn is its own subspecialty in nursing, so it is by no means a comprehensive list of the complications that can occur. But I do want you to be familiar with some of the most common problems that you may see in preterm infants and other infants who are at risk. Here are the objectives for this presentation. Please review these. So if you remember, babies that are born before 37 weeks gestation are considered preterm infants. From there, babies can be resuscitated as young as 22 to 23 weeks gestation. However, the outcomes are a lot more significant, and they may not survive if they're that young. Typically, babies that are born at 23 weeks gestation and beyond, the parents opt to resuscitate them. Babies that are born in that 22-week range, sometimes it's not clear cut as far as whether or not resuscitation should be offered. The parents should be counseled ahead of time about what the survival prediction is if a baby is born at a certain gestation, and also if there's any other complications with the pregnancy or known complications with the baby, those should be discussed with the parents ahead of time as well, so that they can make an informed decision about what's going to be best in the long run for their baby. So babies are classified by weight. So low birth weight, we know are babies that are born under 2,500 grams. But then there are also more categories within that. So very low birth weight baby is a baby that is born at less than 1,500 grams, which in pounds is 3.3 pounds. And extremely low birth weight babies are babies that are born under 1,000 grams, which is under 2.2 pounds. The baby on the right here is an extremely low birth weight baby. You can see that they're just about the same size as the caregiver's hand. So can be very, very small, very, very fragile, and issues can arise very quickly, as you can imagine, in a very underdeveloped baby. The baby on the left is probably more around your 1,500 grams size, so just a comparison between those. So as you can imagine, preterm babies are even more at risk for temperature instability than full-term infants are. Although I do want to mention that full-term infants who are stressed or sick are also more at risk for problems with their temperature than your healthy full-term newborns. So we're going to do our same management strategies that we discussed back on week 1 for managing thermoregulation, appropriate to the baby's needs. So for example, if you have a baby who is in an open crib, who is able to be dressed, you want to make sure that that baby is swaddled, that they have their hat on, that there's no drafts or anything like that. So still check the baby's temperature frequently, every few hours, to make sure that you're maintaining the desired temperature. If you do have a baby that is that is in distress, for example, you would need to place that baby on either a radiant warmer or in an isolette. And a lot of times those isolettes, you're going to set them on a setting where they can be temperature monitored. So in this picture, for example, that baby has a little gold sensor on its abdomen, and the temperature probe is underneath of that little sensor. The Radiant warmer or isolette can be set to a certain temperature that you want that baby's overall core temperature to be, and then the bed will adjust based on the baby's skin temperature to make sure that they maintain the temperature that it's set at. A couple of things that you want to keep in mind when they have this little temperature probe on is that you want to make sure that it's fully uncovered so that the bed or isolette can accurately detect the temperature of the baby's skin. And you also want to make sure that it's on, excuse me, a soft part of the baby. So over the abdomen, for example, you wouldn't want it over a bony area like over the rib cage, for example. And then for very preterm babies, there's some additional steps that are done to make sure that these babies don't lose their heat. So in your book, figure 34.1 shows a baby that is in a plastic bag to protect them against heat loss. So like normally what we do for full-term babies at delivery is that we dry them off and stimulate them to breathe by drying them off. But in very preterm babies, they are not able to tolerate that stress. So we'll put them in a polyethylene plastic bag to prevent them from having evaporative heat loss that way. So take a look at that picture in your book. Another thing that can be done is that a lot of isolettes have the ability to have humidity added to it. So this is done for very preterm babies within the first week of life. We're going to have a humidified environment for them, and that is going to prevent them from losing too much water through transdermal evaporation and heat loss. So humidity can be turned up to as much as 90%. So it's very, very humid in there. It looks like a greenhouse almost. But then based on the baby's electrolyte levels, we are able to wean the humidity percentage down. We're also going to put babies that are very prone to cold stress on a chemical warming mattress, and that's going to be underneath the blanket that they're laying on. Another significant consideration for high-risk newborns is their nutrition. So we know that human milk is best for baby, but not all moms are able to produce breast milk or to produce enough. So if mom's breast milk is not available, we do offer donor breast milk. There is a milk bank. The milk is tested very rigorously to make sure that the milk is safe and disease-free for the baby. For preterm babies, additional calories are added. So typical breast milk is about 19 to 20 calories per ounce. We concentrate that for preterm babies because they are not going to be able to tolerate the volume of milk that they would need if to get enough calories. So we can add different milk fortifiers or some formula powder in them to make the milk higher calorie for the baby. So in the NICU, they have different feeding schedules and they can increase the calories up to 27 to 30 calories per ounce. And just to know, oral nutrition is the goal, but a lot of babies are there in the NICU to work up to being able to feed exclusively orally. Babies do not have a strong enough suck to feed orally typically before 32 weeks gestation. They also have difficulty coordinating the ability to do the sucking, swallowing, and breathing all at the same time. So it takes a lot of practice for premature babies to figure it out. So as the baby gets to that 32-week gestation point and beyond, we may start allowing them to try to take a bottle, but we're not going to offer it to them every feeding because, again, we need to consider that it takes caloric effort and burning through calories to take a bottle. So we're going to slowly work them up to being able to orally feed more as well. So a lot of times babies will have gavage feedings, so they'll either have an NG tube or an OG tube placed. They may be able to, once they're beyond that 32-week point, take part of it orally, and then the rest of it is given through their NG tube or OG tube. It can be given by gravity, or if the baby is very sensitive to the amount of feeding that they're getting, we can put the feeding on a syringe pump and give it slower to them so they can tolerate it better. Another technique that is used in the NICU is non-nutritive sucking. So pacifiers, we use pacifiers a lot to give to the baby while their feeding is going in. That way they can start to develop their sucking reflex and also associate the feeling of getting full when their gavage feeding is going in with sucking. So that really helps them as they're developing those feeding skills. It is also often necessary to give a baby TPN, total parenteral nutrition, so that white bag of IV nutrition. If a baby is very preterm, they are going to be primarily on TPN initially, and then they'll kind of work up on the enteral or oral feedings. So TPN, we don't want to give it through a peripheral IV. It can be very damaging to the veins. So babies are going to have a PICC line placed or a central line, and the nutrition is going to be administered that way. A lot of the care for high-risk newborns is focused on developmental care for them. So positioning, for example, in the NICU, we want to make sure that the baby has positioning rolls around them, that they are contained, and this positioning of them helps with self-regulation during feedings, procedures, and other stressful interventions. We want to try and maintain flexion of the extremities, but again, keeping in mind that your preterm babies are not normally as flexed as your full-term babies, but that containment positioning really helps with their development. We also want to make sure that we're reducing stimuli because it can be very stressful to babies to have a lot of outside stimuli. So if they're in an isolette, the portholes are going to be closed when we're not getting in to provide cares with them. We may even cover their bed with a blanket so that noise is decreased. We can also decrease the lighting in the room and make sure that they have longer periods of uninterrupted sleep so that sleep-wake cycles are promoted and they are not getting stressed out. Another thing to keep in mind is that we want to cluster cares for them. So again, like I said, we want to promote those appropriate sleeping cycles for them. So allow them to have longer periods of sleep to help with their development. If we do need to get in with a baby, we want to try and cluster all of our cares so we can get everything done at once and then be hands off with the baby in between feeding times, for example. This is a picture here of a mom doing kangaroo care. So like we talked about skin to skin care in the other newborn lecture. So basically it is doing skin to skin care with mom and baby. Dad is also welcome to skin to skin care, but it really helps promote bonding with moms and babies. We might even, once that baby is able to start that non-nutritive sucking, the mom might even be able to put baby to breast to do some non-nutritive sucking there. So non-nutritive means that we don't expect the baby to get any nutrition out of that, but it does help with bonding. And if the mom eventually wants to breastfeed, it does help that baby get used to being at the breast. We also want to promote parental touch as much as possible. So knowing that we limit the stimuli and the amount of times that we get in with very preterm babies, it really limits the interaction that parents can have with their sick and unstable newborn, which can be really stressful to a parent. So we really want to encourage them to be involved in their cares as much as they can in any way that they can. So it might be that when it's time to check the baby's temperature, that we're encouraging them to take the temperature. We can encourage them to do the baby's diaper changes. And then when the baby is stable enough to be held or to do kangaroo care, we're going to promote that as much as possible. So it is a very stressful time for parents when they feel helpless. So we're going to try and give them as much autonomy as possible and help them get involved in their baby's care. One of the most common problems that preterm infants have is issues with respiratory distress syndrome. So what that is in a nutshell is a deficiency of surfactant. So remember that surfactant develops mostly within the third trimester of pregnancy. So babies that are born preterm do not have enough surfactant to adequately allow their alveoli to open and close and allow that gas exchange to occur. So the earlier the baby, the more respiratory distress they have typically. They have a decreased number of functional alveoli. The younger they are, the less functional alveoli they have. As I mentioned, that deficiency in the amount of surfactant they have. They also have very small airways, and their nasal passages are very immature. They collapse easily, and if they get blocked, they have more trouble breathing. And the lungs are just underdeveloped in general, the younger that the baby is. So with that, the surfactant deficiency, if you remember, we can give mom up to 2 doses of betamethasone, which helps the baby's lungs mature. And from taking care of preterm babies, I can tell you there is a very significant difference in the how well the baby's lungs are developed, depending on whether or not the mom got betamethasone before she delivered. The other thing that we can do for babies is that we can administer surfactant to them after they're born. So babies are intubated, and surfactant, which is that slippery phospholipid medication, it coats the lungs and it allows those alveoli to open and close. So babies can get a few different doses of that medication if they're desaturating, and it works very, very quickly to improve their saturations. Management for respiratory distress. Babies can be put on nasal cannulas, CPAP, this is a picture here of a baby on CPAP, or mechanical ventilation. So we'll put a pulse ox on baby, and that will determine the type of respiratory support that we offer them. And then we'll also check their blood gases periodically to determine what level of respiratory support that they need. You are not going to need to know all of the different modes of ventilation. There's some different settings and some different types of ventilators that are mentioned in your book. You don't need to know the in-depth details of that, but just know that there are those different modes of providing oxygen for preterm babies. And we also, I wanted to mention that since babies' lungs are so underdeveloped, they're very prone to getting injured, especially from CPAP or being on a ventilator. So we're going to allow their saturations to be a little bit lower, because if we provided enough oxygen or respiratory support to them to make them sat 95 to 100, for example, it can cause more damage to their lungs. So it's kind of a trade-off there. So based on their gestational age, we will allow them to have a little bit lower saturations to prevent any trauma to their lungs. And with the nasal cannula, I also wanted to mention that babies can be given fractions of liters of oxygen, so very, very small amounts, and we can give a percentage of a liter flow. So sometimes they just need a little bit of airflow through the cannula to kind of stimulate their respiratory drive. So we can turn the percentage of oxygen down to as low as 21%, which is room air. If a high-risk baby has respiratory distress for a significant period of time, so over a month, for example, they are then considered to have bronchopulmonary dysplasia. So there's a lot of different factors as to why this occurs. So again, thinking about why respiratory distress happens has to do with surfactant deficiency, immaturity of the lungs. But then as they're on mechanical support for their lungs for a long period of time, it can cause injury to the lungs, barotrauma. The lungs become more stiff and less compliant, and then additional issues can occur. So the baby may be more prone to having fluid overload and need medications such as diuretics, corticosteroids, or bronchodilators to manage the fluid overload. So the prognosis really depends on the degree of the pulmonary dysfunction, and oxygen therapy can occur in the home setting. So this baby is probably at term now. I would guess that this baby was a preterm baby and can go home on oxygen if the parents have been properly trained. So the parents need to learn how to manage the oxygen. They need to take an infant CPR course so that they're familiar with that if needed. The baby will also need to go home on a oxygen saturation monitor, and so the parents need to be trained on that and know how to manage that. A lot of times babies will continue to be able to be weaned off of the oxygen as they continue to grow, but sometimes these are chronic problems. In very rare, severe cases, a baby may need a trach to go home. Another common condition in premature infants is retinopathy of prematurity. So in this process, the retinal vessels of the eye are immature in preterm newborns, and the tissue can become hypoxic when the baby has fluctuating oxygen levels. So we're going to try and stabilize the baby as much as possible on their respiratory oxygen levels. We're going to closely monitor them. And we're going to adjust their oxygen and ventilator settings to make sure that there's a limited fluctuation. However, retinal detachment can still happen, and the vessels of the eye continue to grow, so new abnormal blood vessels form, and they're kind of squiggly blood vessels that are not as they don't function as well as your healthy blood vessels that are supposed to be there. So they get very tortuous and they can cause vision problems in newborns. There's some laser procedures that can be done to help with this, but still, a lot of times, these babies that have retinopathy of prematurity are going to need corrective glasses at a very young age. So I included a picture here of a very young girl that's already wearing glasses, and it's most likely due to retinopathy of prematurity. So if you remember from the normal newborn lecture, the ductus arteriosus is one of the fetal shunts that is open in utero that closes shortly after a baby is born. In preterm babies, a lot of times the ductus arteriosus fails to close or it can reopen after delivery. So with that, a lot of the blood floods to the lungs and causes the baby to have a lot of symptoms from that. So with having less circulating blood throughout their body, they are tachycardic. They may have bounding pulses, which you can palpate, and you may also see an active precordium. They'll have hypotension, and then on the lungs, they will be tachypnic, so have a respiratory rate above 60 breaths per minute. You might hear crackles when you auscultate, and they may also have a decreased urine output because of decreased blood flow going to the kidneys and problems with making urine. So management for that, a lot of times these babies will need fluid restriction. There are some medications that babies can be given that can help close that ductus arteriosus. So examples are indomethacin, ibuprofen, or acetaminophen. So some of those medications will be tried, and if that fails, the baby might need a surgical procedure called a ligation. So a little closure device is inserted to mechanically close the ductus arteriosus. Another major serious complication that can occur in preterm infants is intraventricular hemorrhage. And this happens more often in those preterm infants who are very low birth weight of under 1,500 grams. So the blood vessels of the germinal matrix in the baby's brain are very tiny and fragile and prone to rupturing the younger and smaller that the baby is. So hemorrhage occurs in those blood vessels and can extend into the lateral ventricles, to the third and fourth ventricles, and even to the subarachnoid space and the white matter of the brain. Large clots can create an outflow obstruction in the ventricles. So when babies are more stable, we'll do a head ultrasound to determine the extent of a hemorrhage that a baby has. And it's graded from 1 to 4 on severity. So what the nurses are going to be doing right after that baby is born is they're going to stabilize the baby as much as possible. Any sudden changes in cerebral blood flow can really stress the baby out and cause those bleeds to occur. So in our NICU, we place babies in a neutral head position for the first few days of life to try and maintain the stability of those and to decrease those intraventricular hemorrhages from occurring, because they can occur most often within the first 3 days of life. So we're going to try to stabilize the baby by making sure that their temperature is stable. We're going to do our best to stabilize their oxygenation status, and we're going to handle them as minimally as possible so they're not stressed out. We don't want to have any activities that can increase that cerebral blood flow and cause those bleeds to occur. Obviously, this prognosis can be very scary for parents, so we want to offer support to parents and let them know what to expect as their child grows. That might be missing developmental milestones and having some delays and some cerebral palsy can develop. So we want to provide developmentally appropriate care to the babies while they're there, and we want to make sure that these infants have follow-up as needed after they're discharged. Another serious complication that can occur in high-risk newborns is necrotizing enterocolitis. So that is an inflammation of the GI mucosa which causes necrosis of the bowel or perforation. The exact etiology and pathophysiology is not clear, but some risk factors associated with it include prematurity, asphyxia, getting a red blood cell transfusion, early initiation of enteral feedings, having a patent ductus arteriosus, congenital heart disease, maternal smoking or cocaine use, polycythemia, anemia, a GI infection, or a genetic predisposition. So, for one reason or another, blood flow to the intestines is shunted away and resulting in hypoperfusion. So the abdomen may get very dusky in color, and in very serious cases, sections of the intestine become necrotic and completely die. So this can be a very, very serious infection and can cause a baby to not survive. Um, so some management strategies. So if the baby is feeding at all, we're going to discontinue any oral or tube feeds that the baby is getting and rest that bowel. We're going to place an orogastric tube and put that tube to suction to help decompress the bowel. We're going to start some antibiotics on that baby, and we're going to consult surgery. So the baby might need to have a drain placed in their abdomen, which can be done at the bedside, or depending on the extent of the necrosis to the bowel, they might need to get sections of their intestine removed. And depending on how much intestine is removed, if it is a significant amount, that can lead to feeding problems further on down the road, short gut syndrome, and then they have problems absorbing their nutrition, and will have problems with their growth later on. So it can be a long-term problem for these babies. One of the factors that is considered to be most related to necrotizing enterocolitis, or NEC, is feedings, especially feedings with formula. So we are really going to avoid giving formula to very preterm babies, which is one reason why we offer the donor breast milk in very small amounts initially to kind of help prevent necrotizing enterocolitis from occurring. But it is one of the scariest medical conditions that can occur in a newborn, and unfortunately, a lot of times has a very poor prognosis. Now I'm going to talk about the effects of perinatal substance use and how that impacts the baby. So first, tobacco use. So moms who have used tobacco in pregnancy, the most common feature that we think of is low birth weight. So tobacco is a vasoconstrictor. It causes decreased blood flow through the placenta and umbilical cord and ultimately to baby. So babies are going to be born smaller. There are also some complications during pregnancy that can occur, including miscarriage, preterm birth, abruption, and placenta previa. And then once baby is born, you really want to make sure that if the mom is a smoker, or actually anybody in the family that's going to be around baby, you want to encourage them not to smoke around baby. Newborns that are around secondhand smoke are more likely to have more ear infections, respiratory illnesses, and even sudden infant death syndrome. So really encourage any smokers in the home to go outside to smoke and to wear a separate smoking jacket or something that their smoke can be on that they can then take off so it's not going to be close to baby. And the other disorder I want to talk about in this slide is maternal alcohol use during pregnancy. So fetal alcohol spectrum disorder, so there's a spectrum of, very mild to very severe deficits that the baby might experience. So fetal alcohol syndrome is one of the disorders on that spectrum where the baby has very distinct dysmorphic facial features. This picture here shows a baby with fetal alcohol syndrome. You can see they have very narrow eyes, so those small palpebral fissures. They have a low nasal bridge, epicanthal folds. They might have some ear abnormalities, a very thin upper lip and a smooth philtrum, a small mouth, and a overall small head size, so they have some microcephaly. They also may experience a range of different birth defects, the most common being cardiac and renal anomalies. Some central nervous system abnormalities that they might experience is that these babies are more likely to, as they grow, have learning disabilities, speech problems, behavioral problems, and might be more prone to having ADD or ADHD. And so really it's fetal alcohol syndrome is not something that is diagnosed when a baby is a newborn, but knowing that the mom has alcohol use in her history during pregnancy, as that baby starts to grow and not meet those developmental milestones as we would expect them to, we then think back and think that this might be related to the fact that that baby was exposed to alcohol in utero. Unfortunately, maternal opioid use is fairly common. That can be medications or drugs such as morphine, heroin, methadone, oxycodone, codeine, or fentanyl, for example. These opioids cross the placenta and they do affect baby. In pregnancy, it may lead to miscarriage or preterm labor. There can also be other complications that can occur, but I want to focus on what the newborn acts like once they're born. So many of these babies go through withdrawal. Usually it doesn't kick in until a few days after they're born when they start to withdraw from the medications. And the amount of withdrawal that the baby goes through varies depending on how close to delivery the mom took the substances. So babies that are going through withdrawal or neonatal abstinence syndrome are very restless. They are very difficult to console. They're very irritable and have a high-pitched cry. They can have increased muscle tone. They have a hard time falling asleep and then staying asleep for any length of time. They might have an excessive suck, and so they're going to maybe take in more formula, and they're also going to then have excessive stooling and excoriation from having so many stools. So some protocols have been developed to try and manage these babies. One protocol that they use at OSF is called Eat, Sleep, Console. So with this protocol, we really try to comfort babies and promote sleep between feeding times. So you may see these babies in the newborn nursery kind of off to the side in a room that is dark. We try and keep the sound down. We really want to give them the best chance to get the best sleep that they can because their central nervous system is kind of working in overdrive. So we really want to try and regulate these babies. These babies may need to be started on medications to manage their symptoms. Most commonly, they're started on methadone or morphine. And if these babies are on these controlled substances, they need to stay in the hospital until they are off of those medications. So the medical team and the pharmacist may come up with a protocol where we try and wean that baby off of those medications slowly and get them stabilized. If a mother is in an opioid treatment program, we do our best to make sure that moms and babies can stay together. If the mom is compliant and she is stable on some of the medications that she's taking, such as methadone, she might be able to breastfeed. So again, these babies are, um, you know, very hard to console a lot of times. They can be very frustrating to take care of, but we really want to limit the stimuli as much as possible. Try and keep moms and babies together if possible as well, so these babies can work through that withdrawal process. So as I mentioned, this PowerPoint was just a brief overview of some of the common principles and medical conditions that you might encounter when taking care of high risk and preterm infants. It is not comprehensive by any means, but I hope it gives you a better understanding of this very special patient population.